Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Principal, Pegadas Institute of Medical Sciences. Today, I am going to discuss with you pulse oximetry and a few words on hypoxemia. What is hypoxemia? Hypoxemia is decreased oxygen in the blood, and hypoxia is decreased oxygen in the tissues. You can have hypoxia without hypoxemia. For example, a patient with myocardial infarction, the coronary artery is blocked. So tissue is hypoxic, but the blood level of oxygen is normal. Another example is cyanide poisoning, where oxygen tension in the blood is normal, but at the level of tissue there is decreased oxygenation. So hope this point is clear. So hypoxemia is decreased oxygen in the blood. Hypoxia is decreased oxygenation at the level of tissues. And we can measure the oxygen saturation in the periphery by a simple instrument, pulse oximeter. So we'll be discussing on this today. So let us look into how can you get hypoxemia. It can be basically four mechanisms. One, decreased oxygen in the alveolus. So you can see that if the oxygen in the inspired air is low, you can get definitely hypoxemia. Second mechanism, always remember hypoventilation. When there is a neuromuscular paralysis, as in myasthenia, organophosphorus poisoning sometimes producing muscle weakness, or Guillain-Barré syndrome, high cervical cord injury, all these can be due to hypoventilation. Another important thing is the poisoning with the sedatives. So hypoventilation and decreased oxygen in the alveoli can lead on to hypoxemia. Second is ventilation perfusion mismatch. You can see here the air is entering the lungs and the lung is perfused. Suppose there is a mismatch between this. This is called ventilation perfusion mismatch or VQ mismatch. Think about a condition like pulmonary embolism. So in pulmonary embolism, one of the major vessels, if it is blocked, what will happen? The perfusion going to that area of the lung is decreased. So there is a ventilation perfusion mismatch. Second example is somebody with consolidation. In consolidation, what is happening? The lung is solidified. There is no ventilation, so the perfusion is wasted. So just think about the second condition. Causing hypoxemia is any disease that produces ventilation perfusion mismatch. Third is impaired diffusion. Suppose the alveolus is abnormal and the diffusion is interfered with, for example, in interstitial fibrosis, we can have impaired diffusion and that can lead on to hypoxemia. And finally, cardiac lesions like the shunt lesion, right to left shunt, congenital cyanotic heart disease, or Eisenmenger syndrome, that is left to right shunt becoming right to left, that becomes patient becomes cyanotic because of the intracardiac shunting. Shunting can occur at the level of alveoli, suppose there is alveolus is collapsed, or arteriovenous malformation, or hepatopulmonary syndrome. So we have gone into the major causes for hypoxemia, that is hypoventilation, ventilation perfusion mismatch, impaired diffusion capacity of the lung, and shunt lesions at the cardiac level or at the level of the lungs. Now we look into how will you measure hypoxemia. This can be done at the periphery by pulse oximetry, and the value is called SpO2, that is saturation, peripheral saturation of oxygen, SpO2. Pulse oximetry is a non-invasive continuous measurement of the oxygen saturation of hemoglobin. So you have to remember we are measuring the saturation, percentage of hemoglobin that is oxygenated. That is the pulse oximetry shows a percentage saturation of hemoglobin. That is, hemoglobin is in the pulse oximetry is based on Lambert Law. When light is passed through a solution, there is a linear relationship between the concentration and the absorbance of the solution. That is, light is passed and light is absorbed by the solution. It has got a linear relationship between the concentration of the substance in the solution. And from this, concentration can be calculated by measuring the absorbance. So this is the basic principle, that is, light is passed through a solution and the absorbance depends upon the concentration of the material, and this concentration can be calculated from the absorbance of the light. So let us look into little more detail. This is the RBC showing having the hemoglobin inside, and in the hemoglobin the heme contains iron, and iron is in the ferrous state. And when the heme is in the ferric state, it is called methemoglobin. So normally hemoglobin is the iron is in the ferrous state. And this is the hemoglobin molecule, and the ferrous ion has capacity for attaching to oxygen. Or only when the iron is in the ferrous state, hemoglobin will be able to carry oxygen. When the oxygen is there, the hemoglobin is called oxyhemoglobin, and the oxygen is released to the tissue, it is called deoxyhemoglobin. When the light is passing through, there is a difference between the absorption of lights of varying wavelength by oxyhemoglobin and deoxyhemoglobin. So the oxyhemoglobin is in the relaxed form, and the reduced hemoglobin is called in the taut form, called R and T forms. R for relaxed and T for the taut form. So here you can see that the finger is kept in the pulse oximeter. Two lights are passed through. Lights of two wavelengths are passed through. Usually we see only the red light. That is why when you put the finger inside the pulse oximeter, you see a red color. There is infrared light is also passed through. The red light is in the wavelength of 660 nanometer, and the infrared red light is in the wavelength of 940 nanometer. So remember this: 660 red light and 940 infrared lights. As already I have mentioned, oxyhemoglobin and deoxyhemoglobin can be differentiated by the adsorption of red and infrared light. The oxyhemoglobin adsorbs more of infrared light, and the deoxyhemoglobin adsorbs more of red light. And from this, the ratio of red bar and infrared absorption, or the modulation ratio, is used to calculate the saturation of oxygen in the periphery, or SpO2. So this is and you can see here it is 97. SpO2 is written as 97. That means 97% of the hemoglobin is in the oxyhemoglobin. So this is the value that you should remember. That is, it is the percentage of oxygenated hemoglobin that is shown by the pulse oximetry. On the side you can see the heart rate also. So below the the percentage of oxygen, you can see a wave like this. This is called a photoplethysmograph, or PPG. So what is happening? You can see in the pulse oximeter there is a source of light, and there is a sensor which absorbs the light. When the during systole and diastole, the blood vessel size is changing. And this is shown as a graph below. You can see, and above you can see the electrocardiogram. ECG also can be seen in some machines. So hope this point is clear. That is a photoplethysmograph. So where will you keep the machine? Commonly it is kept over the finger. Thumb can also be used. It can be kept on the ears. And no probe is clearly superior. By trial and error, you can identify the best probe and the type for the particular individual. There are several factors that may interfere with the accuracy of pulse oximetry. One of them is skin pigmentation. Second is nail polish. Third, non-pulsatile blood flow as occurring in hypotension or patient on ECMO. Abnormal hemoglobins and very low partial pressure of oxygen. These are factors which may interfere with the accuracy of pulse oximetry. Let us look into pigmentation. Especially in dark skinned people, this will overestimate SpO2. So that, and hypoxemia may be there and it may be missed in a highly pigmented person. This should be kept in mind. The fingernail polish, it decreases the accuracy of pulse oximetry, particularly when used are the darker colors like blue, green, black and brown. So nail polish should be removed before applying the pulse oximeter. In ECMO or left ventricular assist device, or patients with the low flow states, blood flow is comparatively non-pulsatile and the values may be inaccurate. It's important to keep in mind abnormal hemoglobin. I have told you that hemoglobin, the iron molecule is in the ferrous stage and the iron in the heme is in the ferric, it is called methemoglobin. So this is the ferrous state and here it is the methemoglobin. As I have already told, in pulse oximetry, only oxy and deoxyhemoglobin, their amount is only measured, or in the calculation of SpO2, only these two hemoglobins are kept into consideration. And so in patients with methemoglobinemia, which can be either congenital or acquired one, we can get a false SpO2. Another is carboxyhemoglobin. This may give a elevated SpO2 in the range of 94 to 100%. So patient with carbon monoxide poisoning, the partial pressure can be falsely or give false sense of security. Sulfhemoglobin on the other hand gives low values of SpO2. When the hemoglobin A1C is more than 7, it may also give a over estimation of SpO2, but it is not of much significance. Abnormal hemoglobins like sulfhemoglobin and methemoglobin can be identified by CO-Oximetry, where abnormal hemoglobins are also taken into consideration by giving lights of varying wavelengths. Methemoglobinemia is particularly important because it can give refractory hypoxemia. Even when the SpO2 Even when the PaO2, that is partial pressure of oxygen, by an ABG analysis is high, this may give a low value. And usually it is in the range of 82 to 86 or 80s. The reason is methemoglobin has high adsorbance for both red light and infrared light. So it causes inaccurate SpO2 reading. When the methemoglobin level is around 30 to 35%, the ratio of adsorbance becomes 1. And this is read as an SpO2 of 85%. So patients with methemoglobinemia, for example, patient given highly oxidizing drugs like nitroglycerin, patients on dapsone, once they develop acquired methemoglobinemia, even from the partial pressure is high, partial pressure of oxygen is high, the SpO2 will be low and it may be considered as refractory hypoxemia. So when the values are indeterminate, go for arterial blood gas analysis. And hemoglobin can be converted to methemoglobin in case of oxidative stress. And methemoglobin, the ion is in the ferric state and is made into ferrous state by various mechanisms in the body. The most important is the cytochrome B2 reductase enzyme. Mutations in this enzyme can lead on to congenital methemoglobinemia. Acquired ones are due to oxidative stress. Again, remember, the pulse oximetry may be inaccurate when the partial pressure of oxygen is very low. This is because of the sigmoid shape of the oxygen dissociation curve. Here you can clearly see that even when the partial pressure of oxygen, that is PaO2, is around 60, the SpO2 can be nearly 90. Only once the SpO2 becomes less than 85, you get cyanosis, and by that time the oxygen tension in the blood is very low. The PaO2 is usually between 90 to 100. That's you consider as, or 95 to 100 is the usual normal. So this point to be kept in mind when you are reading SpO2. That is, SpO2 is not a sensitive method to determine PaO2. That is, only once a significant drop in PaO2, you get a lower SpO2. This should be kept in mind. Another important point is hyperoxia. Following cardiac arrest, you always give oxygen, but again your target SpO2 should be around 94. Don't try to make it 100%. The reason is pulse oximetry cannot differentiate supranormal partial pressure of oxygen. It will be given as SpO2 100%. So remember this point. A hyperoxia cannot be identified by SpO2. It will be around 100 only. Hyperoxia is harmful, so that is the reason, especially patients with a cardiac arrest, you should be careful in giving hyperoxia. One word regarding pulse ox lag time. So here you can see the red color, it is the blood saturation, that is PaO2. Following cardiac arrest, once you revive, it will go back to normal. So, but you can see here that there is a lag between the rise in PaO2 and rise in the SpO2. This should be, and that is why a patient, even once we are revived from an arrest, the SpO2 may tend to fall for some more time. A few seconds this may last. We can get falsely low SpO2 readings when patient is given methylene blue or fluorescent dye or indocyanin green. So that should also be kept in mind. So these are the factors that will interfere with the measurement of SpO2. This has been already discussed, the relationship between partial pressure of oxygen by ABG and the peripheral saturation of oxygen, the relationship. That is, only when the oxygen tension comes below 60, SpO2 tend to fall below the normal range. One word regarding pulse transit time. In some of the machines, we can see the ECG, and you can, this is the lower one is the Photoplethysmograph. The interval from the electrocardiogram, the R wave of the electrocardiogram, and the peak in the PPG, that is called pulse transit time. And this is an indirect evidence of arterial compliance. By looking into the waveforms, that is a PPG or Photoplethysmograph, we can have some idea regarding the cardiac activity. What is the peripheral arterial compliance? What is the cardiac output? We have already mentioned about the CO-Oximetry. When the SpO2 is indeterminate and you are suspecting abnormal hemoglobins, CO-Oximetry is used. So, lights of 4 different wavelengths are used, and 4 hemoglobin derivatives can be identified. That is oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, and methemoglobin. So in patients with the carbon monoxide poisoning and methemoglobin, CO-Oximetry will be able to identify abnormal hemoglobins. So in short, we have discussed what is hypoxia, what is hypoxemia, and how to utilize pulse oximetry for measuring saturation of oxygen in the periphery, factors interfering with the values, and the PPG or Photoplethysmograph and pulse oximetry. If you like this channel, subscribe to it and share and give your comments. Thank you.